One variant of this is what's called the simple running locking suture. Sometimes you are closing a wound quickly, and an example would be maybe a big scalp wound where it's bleeding and you just need to get it closed. And it's hard because it's gaping open a little bit. As you start to tie and tie your suture, it's not staying in place. Sometimes you can have an assistant hold that for you, but when you're by yourself especially, what you can do is you can lock the stitch each time. And what I mean by that is you take your simple bite, and now before you pull it completely through, you take the needle and you pass it through the loop. So now it's like a little pulley closed down and it locks it down. And then you go ahead and take your next stitch and make sure it comes back through the loop. And so what you see here is that you can do a pretty long suture line and not worry about it untying behind you as you go. Again, probably adds more suture to the skin, therefore it's not as good necessarily for cosmesis, but certainly for something like bleeding, like in a scalp wound or a wound where you're just trying to get something closed quickly, works perfectly. And I always end these types of running sutures just by grabbing the loop and then doing your instrument tie once again. Again, 2 times around will lock it. If you're having problems with it locking, you can even wrap it 3 times around the needle driver, and that really holds it in place. Only 1 time around for each subsequent. So now we're getting to fancier closures. A subcuticular closure is really what I would call a cosmetic closure. The idea here is to close the skin and not have any suture in the wound at all. So we'll go ahead and apply the Vada device to the pad so it spreads it apart for us, or gives us a little bit of spread. And now what we're going to do is run a stitch under the skin, and this can be done either with permanent suture or absorbable suture, and I'll demonstrate here with permanent suture. So I'll enter from outside and enter just at the level of the deep dermis, and the key here now is to take horizontal bites in that deep dermis, exactly the same on both sides, and advance as you go. And what you see is I'm pulling the suture across to show where the next stitch should be, so I make sure there's no bunching. But what you can find over time is that it really doesn't matter how much you advance as long as you're doing the same each time. I will tell you, if you're hoping to pull this stitch out later, like maybe after a week, then you'd want to advance more each time. If you know it's a permanent suture that's going to stay in there, like something absorbable maybe, where you're not going to have to remove it, then you want to almost go back to the last stitch each time. So there are different variants, but the key is do the same thing each time. Now the skin is beautifully opposed, and on this I probably would still put steri strips or put some skin glue, but it's really the suture that's holding everything together. One of the advantages of the Vada pad is that all the layers of closure are represented. So we not only have the skin and dermis, we also have some fat, which feels very lifelike. And then deeper we see the white, what I will call fascia, or the lining of the muscle, and below is some red, which represents muscle. Generally the strength of closure, especially in deeper wounds, is going to be that deeper white fascia. So if we just close the skin here, there almost would be this potential space underneath where fluid could collect, or the skin would have so much tension on it, it ultimately would pull apart. This is especially true over joints, where you're bending the arm or bending the knee, and you might pull things apart. So what we'll do here is we'll first close the fascia. Because fascia is generally so deep to the skin, I usually don't bury the knot. You certainly could, but you don't have to. So for simplicity's sake, I just do simple suture here. In some situations, we might use a permanent suture here. Certainly you can use absorbable as well, so it's kind of surgeon's choice. And remember, you're pretty deep here, so you're going to want to not only lock the knot, but then once you're pulling things down, it's almost easier to pull it along the wound itself. Otherwise, the skin may prevent you from tying all the way down. So we're going to put a couple of interrupted simple stitches here to close the fascia. And again, you sort of put a stitch in, see what it does, put a stitch in, see what it does. You know, that's the way that we do it in surgery. Sometimes you need a lot of stitches, sometimes you don't. Stitches are foreign body, so potentially if you're worried about infection and things like that, you'd use an absorbable suture, so it's not going to hang around, or at least less permanent suture. If you're not locking, remember you can always throw an extra throw, like 3 throws, or you can just do what I just did, which is sort of lock it down by pulling on it. Once the fascia is closed, you kind of have a decision to make. You can go right to the dermis, or you can look for, in some parts of the body, there's what's called scarpa's fascia. So you could potentially close another layer. Here I'm going to close the deep dermis, and it's going to include some of that fatty tissue, which would theoretically be like a scarpa's fascia. But the dermis is the strength here. Again, this is a buried knot because this is the next layer of closure. So we started deep and went superficial, and then superficial and deep. You can see there is some tension on this wound, and I think that's what I like about this demonstration and this type of model, is that it is realistic, and you can set this tension as much as you want, and early on you'll be able to close the ones without tension pretty well, and as you start moving along you'll want to put more and more tension on and see how good your knots are and how good your suturing is. Another word of advice I would give you is notice how I'm going to the ends first. The ends have the least amount of tension, the middle of the wound gapes open the most, and I think most of the time people want to close the middle first. If you sort of sneak up on it though and start closing the ends first, you'll take the tension off, so by the time you get to that middle stitch, it'll have the least amount of tension on it. So here we have two, and I'm going to put one more. Notice I'm grabbing deep dermis, starting deep, coming superficial, and I'll grab right above the dermis on the other side, come out the same distance, and when I tie it together then, what we're doing is getting these skin edges closer together and getting them closer together at about the same level, so that when we're finally closed and the skin is closed, we have a beautiful closure. Okay, so now we have the dermis closed. Now we're going to have our skin closure. This is your closure of choice. You can do a running suture, you can do interrupted. This will totally be up to you. Here, because it's a complex closure and I believe it's under a lot of tension, I'm using the vertical mattress. I told you this is probably the best suture for wounds that are difficult to close and under a lot of tension, because you're grabbing a lot of tissue to a lot of tissue, and because you're starting far away and because your second bite is close, what that does when you tie it, it literally everts the wound, and so the skin edges pout out, which gives you proper healing. If you don't place your sutures properly, the skin can turn in, and epidermis, the outer layer of skin touching epidermis, is not going to heal. So you'll take your stitches out and your wound will kind of break open, and you'll wonder why. It's because you didn't approximate your edges. Something we do fairly often in the operating room is skin stapling. It seems like it's a fairly simple thing to do, but what I would tell you is approximation of the skin is key. Oftentimes I'll use either one or two pickups to position the skin properly, everting it, bringing it together, and then taking a stapling device similar to the one that comes with your kit. Simply center the device on the skin, staple it down. It literally will grab the edges and then turn them in, which helps to evert their edges, which again is very helpful. So stapling is nice because it's fast and will turn the edges out. So here I'm approximating the skin, everting it, getting it close together so that the skin edges are touching, and then placing the stapler. And you don't need necessarily to push down very hard. I think a very controlled motion is key, that when you're stapling, the end of the stapler is not really moving at all. Try to grab it near the end of the stapler. You'll have more sort of torque advantage. And again, just like simple sutures, you have to decide how many staples you need and what each wound needs for approximation. In a case like this, if this were a complex wound, we have multiple layers of closure, a staple might be nice because I'm going to leave these staples in for a few weeks. And generally, where sutures can get infected, metal staples do not. Well, how do we take these out? This is a staple remover. Basically, it'll grab the staple, which has turned its edges in to approximate, and will open the edges of the staple, and then it'll straighten them so they pull right out. And so here you see, as you push down on the staple remover, it unbends those ends of the staple, it aligns them so now they become straight, and then the staple will literally simply lift out of the wound, very simply. So we push down, spreads it, and as it straightens it, it just pops straight up. If you don't have a staple remover, you can also use a needle driver or a clamp and place it under the staple and just spread, and basically spreading is doing the same thing. It's straightening out. This is much less painful for your patient though if you can use one of these devices, because as I said, it straightens everything out and simply pulls out, and there's no pulling. Sometimes if the bending apparatus doesn't really straighten them completely, you can just, as you're stapling, rock it gently. And here's an example with just a needle driver where literally you just spread, so you're trying to open those tines, and as it does, it'll come out. If you're going to do this, it's usually better to do this on a patient who's asleep because it can hurt to remove staples this way. And again,